Hi, I'm Dr. Mallios. I'm a vascular surgeon. I'm dealing a lot with vascular access in Paris, France, at the Paris Saint-Joseph Hospital and at the hospital of Chartres. We are very happy to see the 5-year results from IN.PACT AV trial that was presented by Dr. Holden. It's very interesting and very positive to see that the results are consistently positive and in favor for the use of DCB and in particular IN.PACT AV for AV access. This strengthens my conviction in terms of applying this therapy for my patients, especially when they have restenosis in their AV. Considering treatment standard of care probably requires more data. We definitely have one big, very positive trial, which is the IN.PACT AV. But at this moment, this is the only trial, and in general, I think longer follow-up and more trials and more clinical data are required, but we are definitely at the right path for getting there. In terms of the location of using the device for users that are not familiar with it, I would not necessarily have a specific location, but what I would recommend, especially in restenosis and by the use of ultrasound, when there is a suspicion of neointimal hyperplasia, definitely to apply a long inflation and preparation of the vessel with a normal or high pressure balloon, and then apply the IN.PACT AV balloon with a long inflation and also extending the balloon before and after the lesion. I think these are important elements for successful treatment. What we see regarding quality of life, first of all, is that the reduction of interventions and the number of interventions needed is what might improve quality of life for patients. The other element that we saw for the 5 years data, of course, is that we don't have this stressful potential for mortality amongst users that are being treated with DCBs. So I think we have important positive clinical outcomes, but also reassurance of patients and physicians. Comparing this trial with the other clinical data we have so far for AV, I think what makes this trial standing out is that it's the only piece of data and evidence we have about DCB that is unequivocal. For the other trials, we had some questions of interpretation, having some results that were statistically significant for some time intervals or for some types of analysis and for other data points not necessarily. For this particular trial, I think the data are unequivocal and consistent for the entire time period. I don't think that there is anything that can act as a magic stick in medicine, in surgery, or in AV access in particular. And I don't think that anyone would claim that DCBs is the absolute treatment for any problem, but it's definitely a very useful addition, and all the data are pointing that it is something that we need to have in hand available and to implement in some of our patients if we want to optimize our results.
Hello, I'm Andrew Holden from Auckland, New Zealand, and I'm here to discuss the Medtronic IN.PACT AV Access randomised controlled trial. The key takeaway of the IN.PACT AV Access randomised controlled trial was that the experimental arm, that is angioplasty with the IN.PACT AV drug-coated balloon, provided a patency benefit compared to plain balloon angioplasty for stenoses in the AV access circuit. Not only at the primary endpoint at 6 months, but we've seen at endpoints right out to 3 years a statistically significant patency benefit for the drug-coated balloon over plain balloon angioplasty. We've seen a patency benefit for the IN.PACT DCB over standard plain balloons in all locations and all types of stenotic lesions in the AV access circuit. But for those really wanting to start off, perhaps we may use it in the areas that are even more powerfully responding. Things like a restenotic rather than a de novo stenosis, or a stenosis at the AV anastomosis or cephalic arch, or smaller vessel diameters. These areas even preferentially show a better response with the drug-coated balloon. Our approach, given the data, is that it's now a standard of care. I actually think we're very close to societal guidelines recommending the use of the IN.PACT AV drug-coated balloon as standard of care. And really, I can't imagine a lesion that I wouldn't use the IN.PACT AV drug-coated balloon. We have seen obviously some other trials of drug-coated balloons in AV access, and they've failed their primary efficacy endpoint. There might be a number of reasons, some differences in the patient population and the trial design, but we know also some important differences in the device itself. There have been some other trials that have shown devices such as covered stents to show us perhaps a similar but not superior result to the IN.PACT AV drug-coated balloon. And of course, the drug-coated balloon leaves nothing behind. And finally, I would say we actually have some really interesting data showing that this therapy is cost effective because of the reduction in restenosis.